Okay. We're live now. Hello, everyone. Welcome back to another virtual dental challenge session. Today, we're joined by Dr. Milica, who is an international trained dentist, currently on her way to endodontic residency. Thank you for joining us, and the floor is yours.
Thank you so much. Hello, everyone. My name is Milica Novakovic. Everyone knows me as Mitzi, so that's my preferred name here. I am, as I said, internationally trained dentist. I actually come from Serbia, so I graduated from dental school in Serbia, now 11 years ago, and I worked as a dentist. I did a year of GPR there. Then I worked as a general dentist for 2 years before I moved to the United States. After I moved to the United States, I decided I will pursue advanced standing programs. So I got accepted to UIC advanced standing, and I graduated from there in 2020. And during my time at UIC, at advanced standing at UIC, I decided I want to specialize endo, and I applied to endo, and I got accepted that same cycle in at UIC as well. So I just transitioned straight from advanced standing to endo. I'm currently a second year resident, and I will be graduating in end of June, beginning of July. I think my graduation date is July 1st. And I'll be joining the real world after that. And that's pretty much what I already told you. One interesting thing about me is that I like to, say this to people, I'm left-handed. Now, that's not a big deal here, but back in Serbia, their dental school did not accommodate left-handed dentists. So when you start the training, you simply have to learn how to work with your right hand. So I had to develop ambidexterity, believe it or not. So I earned my degree as a right-handed person, and I also practiced dentistry as a right-handed person. And then when I moved to the United States, I was like, okay, here, I can be accommodated with with my preferred hand, so I switched to left hand. But I still have a pretty good degree of ambidexterity, but obviously that's something that you have to practice on a daily basis to maintain it at the same level. So yeah, that's it about me. Now, if you ask me what maybe to a competitive applicant, if we're talking about the advanced standing program, that's a good question. I feel like I wrote a good personal statement. And that's probably something that was interesting to them. I actually mentioned all these things that I just told you about, being a left-handed person, and then developing ambidexterity is something interesting, because I feel like, that demonstrates that you don't get discouraged and that you're willing to work in spite of adversity, and also shows that you have determination, and that you can develop hand skills. I also had, I was a good student overseas. I had decent experience. I had some research experience as well. So it was kind of a diverse set of skills that I was bringing. But I feel like that personal statement made me stand out more than anything else, because you have all these people, with PhDs, with masters and all that applying, and I don't have any of that. I did not. Another thing that I did not have is, a lot of people that apply to AS program already works as dental assistants. Well, I did not have that. I did work as assistant, but actually after I submitted my application, so that simply did not count. So one thing and one advice that I would give to people who are trying to pursue advanced standing program is to get exposed to dentistry in the United States, to shadow a dentist, or to volunteer as dental assistants. But obviously, if you can get a paid dental assistant job, that ranks probably best. And they tend to like that, at least at UIC program, but I believe at other programs as well. Now, for endo program, I was already a UIC student. That year, I decided to push my luck and apply only to UIC endo program, which probably is not the smartest thing to do, but I was just, because of my personal life, I was not ready to move anywhere else. So I was like, you know what, I'll apply here and let's see what happens. And I guess, what mattered most is that was a UIC, that was my school. They already knew me there. I had good reputation. I was a good dentist. I was ranked number one in the class and had really good clinical performance. I also was a TA at preclinical endo. So all the endo faculty, which a lot of them was on admissions committee, already knew me. So that was probably my route to endo more than anything else. If I had applied to any other program, obviously I would have had to do something different. But again, for UIC, I feel like just the fact that they knew me, they knew who I am, and I had this reputation at that school, it was not hard for them to pick me over somebody that they did not know anything about. Now, when choosing specialties, well, for me, I can tell you, I've been a dentist for 11 years, and endo was not my first love. Definitely not. Endo is hard. And back, in Serbia, in my dental school, they used to teach us to do endo with the hand instruments. And that's very hard. That's very technique sensitive. And I did not enjoy it. I did not like it. I did not learn it. And then I only learned how to do endo when I actually when I actually graduated and started practicing. And that's when I got introduced to rotary instruments. And I started liking it. I started like, oh, I'm digging this. It's not too bad. I also had a chance, while working as a dentist, I had a chance to be mentored by two amazing people who do amazing endo. One of them is a general dentist. The other one is an endodontist. And a lot of what I know, or what I knew until I came here is thanks to them. My first love overseas was actually oral surgery, and that's what I wanted to do as while I was a dental student. However, the situation over there is such that you actually can't go to specialty directly after graduation. You have to work as a general dentist for 2 years first. So as I started working as a general dentist, I actually realized I really love prost. I got really good at it. I got a pretty good restorative dentist. And that's when I started, thinking about prost as well. Now, when I moved here, I was enjoying restorative so much that I still was considering prost. But I also thought, endo is, what I love about endo is really that it's technically challenging. You use a lot of equipment, a lot of toys. You have a microscope, you have CVC, you have all these things to, and I love that. I like toys. I'm a nerd. So that's one thing. Another thing is that it's fairly short residency. It's 2 years, and just considering my age, I don't want to be stuck in school for 6 years doing OS. I don't want to. For me, that's not for me. That's for somebody who's in their early 20s. So that's one thing. And I feel like with endo, it's hard on one hand. On the other hand, it's fairly repetitive. So the more you do it, you get really good at it, and you're kind of doing almost it's still a fairly narrow field, so you can get really good at it. On the other hand, one thing I love about endo is that it keeps you humble. So you can do 10 amazing cases in a row, and then the 11th one, something's going to go wrong. You're going to screw something up, and still keeps you grounded. Shows you that you still don't know everything. You're still not the best. When you ask me what's a typical day like as a dentist, so one thing that we as I'm going to talk now as as an endodontist or endo resident at this point. One thing that we see a lot is that patients are coming in pain, and when it's not just dental pain, it's all sorts of pain. So diagnosing what kind of pain are they coming with, and what needs to be done, if anything, is really the hardest part. The diagnosis is always the hardest part. Sometimes it's very obvious, it's very straightforward, but a lot of times it's not, and that's where you have to learn how to draw a line. What do we treat if we and what do we not treat if we're not sure? That's a very fine line. That's something that you get with experience and training. My day as a resident starts around 8 in the morning, sometimes a little earlier. Typically, we have between 8 and 9 or 9:30. We will have classes, and then we start clinic from 9 to 12:30. So we typically see one consult, one treatment. Sometimes we can see like 2 treatments. Sometimes we see 2 consults, but typically about 3 patients in the morning. And I'm not counting follow-ups. Follow-ups are typically short visits, so we see those as well. Then we have a lunch break, 12:30 to 1:30. Then again back to patient care, and pretty much the same thing. You see at least 1 consult, 1 treatment. Sometimes you see a couple of consults and a couple of treatments. After 4:30, sometimes we have classes. Sometimes on some days you just have to go home and do your homework. A lot of studying, but on some days after school we moonlight. And I don't know what kind of audience I'm dealing with, and I don't know if they know what moonlighting is, but that's essentially when you as an endo resident go to other people's practices and do their root canals. Pretty much everyone does that. Not all programs allow that, but UIC Endo does, and all of the residents moonlight. So that's kind of nice way to try how does it work, how does a real life endo work, and also make a little bit of money, just something to help you out. And now we're gonna move on to cases. I'm presenting 3 cases here for you. The case that you see on the right side, that's a pre-op x-ray of a tooth number 19, which is a lower first molar. This is a 12-year-old patient, healthy, no remarkable medical history. She came with a pain and extraoral swelling in the left cheek area. This tooth, number 19, as you can see, was previously treated 3 years prior, and now presents with a large acute apical abscess. You see this large radiolucency, this gray area between the roots, that's really infection. And what happened was when this tooth was treated, it was a vital case back then, the furcation was perforated, it was unrecognized and unrepaired. And as a result of that, patient developed this infection that she came back with 3 years later. So treatment plan at this point, we could have extracted the tooth, but I decided to still give it a good try and save it, because this is a young patient. Young people tend to heal very well, and she's not a candidate for implant at this point because of her age. So we were like, okay, maybe it's not the good prognosis, it's kind of unfavorable, but let's go ahead and try. So what I did in the first visit, I did an incision and drainage to evacuate the pus from her cheek, and I did a perforation. I accessed the tooth through the crown, removed all this previous buildup material, and visualized the perforation and repaired it with bioceramic material. And the next time I saw the patient, I proceeded to remove the root canal fill and place calcium hydroxide as an interim medication. And then in third visit, I actually completed the retreatment. And the next picture you see is this is just on the left side is a perforation repair. So you can see kind of this white little like a plug in the furcation. That's the size of the perforation. That's where the perforation was. And here you can just see my calcium hydroxide. And the next slide on the left side, this is my post-op. So when I completed the retreatment, this is what it looked like. Okay, you see the perfect there, you see these nicely filled canals. Now on the right side is a 6 months follow-up. So you see how wonderfully this infection has healed. See, there's still a little bit of healing that needs to happen here in the furcal area, but this looks amazing. After only 6 months to have this much healing, I was very excited to see this. So I'm expecting now that the prognosis of this tooth is pretty good, and that this patient will keep this tooth at least until she's old enough to get an implant, if not longer than that. So that was our case number one. Our case number two, this is kind of an interesting case, and I included it just to show you the scope of what we do is not always just root canals. So this is a young patient, a 30-year-old with unremarkable medical history. She came, so what the story with this tooth, this is a tooth 23. So she came, she had external root resorption on this tooth 5 years ago. And she had that root canal and perforation repaired back in 2016. Now, fast forward to 2021, she comes back with a sinus tract between this lateral incisor and the canine here. And you can see, you can appreciate here, this dark field over here, that's the infection. That's where the sinus tract was coming from. So I took a three-dimensional scan, CBCT, and it was showing this root canal was not failing. It was a perfectly done root canal. If you look at the apical area, there's no infection there. So what is really going on here? We have, and this tooth has, grade 2 mobility. It's very wiggly. It's not stable because it's missing so much bone on the side. So what do? We could retreat it, but again, this doesn't seem like a failing root canal, so we're not going to achieve anything. So we decided, why don't we go straight to surgery, raise the flap, and see what's going on, and maybe that's going to give us some insight into why is this failing. Maybe we're going to see a fracture, maybe something like that. So I decided to do surgery. You can see on the left, that's after I opened up the field. And as I was there, I decided to also resect the root and retroprep it from the side to seal it. So just to address if there's any endodontic component to this sinus tract, that retroprep and retrofill would address it. And on the right side, you see after I retrofilled and removed curetted the lesion and bone grafted, this is what it looks like. So this is my retroprep filled with the bioceramic material. This is this all here, that's a graft material. Whatever tissue I removed, I sent it to biopsy, and it came back as a periradicular cyst, which was quite interesting. Why did the cyst happen on the lateral side of the root and not on the apex? I still don't have an answer to that. But this was a very, very interesting case, and it just showed that it was a good idea to do surgery because cyst would not have healed if we had done anything else. And our case number 3 is another interesting retreatment case. This gentleman is in his 50s with unremarkable medical history. This root canal was done a long time ago somewhere overseas, and he's asymptomatic. He came to UIC wanting to get a comprehensive care, and when they took his FMX, they realized that he had this radiolucency, so they sent him here. So this is the tooth that you see in front of you is number 14. There are multiple problems with that. So you see the palatal canal over here is not filled all the way to the end. It's kind of short. Same with the distal buccal. With the mesiobuccal, you can see there's a separated instrument in one of the canals, and then the other canal was not even filled. And this thing right here, that's the infection. Okay, so when I took a scan kind of confirmed all these things. There was no infection on the other two. On this. Do you guys hear me?
The voice was a little bit low just a second ago.
Can you guys hear me?
Yes.
Okay, perfect. For some reason, my computer just switched my microphone from the computer to the headphones, which is kind of funny because headphones were closed, so I don't know. But anyways, that's what happened. Back to the case, when I took the CBCT, it kind of showed, confirmed all these things, those two short fills. I also noticed that the fill in a distal buccal root was kind of off-center. And that's interesting because whenever you see that something's off-center, you should suspect another canal. And that's it. So what I did with this case is, went in there, removed these old root canal fills, gained the length on other canals. I found another distal buccal canal, which is, again, pretty rare to encounter. Most of the time, this distal buccal roots have only one canal. And then I was able to remove the file from MB1, and I was able to find the MB2. And this is my final radiograph, so just from two different angles. So you can see, NB1, NB2, this is where the file was. I had to remove some extra dentin to remove that file, but we got all these nice canals, nice length. And another thing that's, as I said, interesting about this case is the two distal buccal canals that finally emerge more. I don't have a follow-up for this case. It's still too early. I've done this a couple of months ago, but I'm hoping that I'm going to see some nice healing, and I may be able to use this case as a board's for board certification. That's all about cases. And question about what is the hardest thing about being a dentist. I think there's plenty of hard things, but as from endo standpoint, I think the hardest thing is really knowing when not to treat, when is the patient not presenting with dental pathology. And the reason I say that is because it's very interesting. When you see these patients that come with all sorts of orificial pains that are not of odontogenic origin, sometimes they're trying to solicit treatment. Sometimes they are pushing you. Sometimes they're even faking their symptoms just so that they get the treatment because they believe that's going to help them. But then if you fall into that and trap and start following that route, you're going to do excessive, unnecessary, and counterproductive treatment, and you're not doing them a service. So you really need to be careful, really need to know when is the time to do nothing. As dentists, we are prone to look for problems. We're prone to look for solutions. We're prone to treat thinking that that's going to help. But learning where those fine line is really not to do anything to avoid over-treatment, doing patients disservice, and any also legal headaches along the way. You have to know when not to do anything. And that's one of the harder things that comes with experience. And I believe that's all I have for you.
Thank you, Dr. Mitzi. Would you mind, before I start the question, would you mind switch back to the computer audio? I think that's better than the headphone.
No problem. Let me do that.
Thank you so much. Let me see.
Okay, do we hear each other?
Yeah, now it's better. Okay, so the first question is, how do you manage life with residency?
Oh, that's a great question. I have to tell you one thing, first year of residency has been rough. There was so much coursework that you could not imagine. Like if you think dental school is hard, trust me, residency is a lot harder. I could say that in the first year of residency, I've learned more than the whole dental school. So how do you manage life? I don't know. You just, try, take it day by day and, do your best to survive. But it's definitely has been time of sleep deprivation for sure. So it's hard. First year of residency is very hard. You pretty much don't have a life, but you have your goal. You want to finish your first year, so you need to tell yourself it's just 1 year. But yeah, it's very hard. I feel like you need to sacrifice most in that first year. Now as a second year, things are a lot easier for me. I have a lot less coursework to do. Obviously, I have other things. I have master's thesis and boards coming up, but it's still a lot easier. So first year is the hardest one for sure.
Mm-hmm. And how, is it mentally difficult or physically demanding? Which kind of?
I would say both. That's a good question. It's mentally draining to have so much coursework, so much homework, and always feel that you're behind. And also in the clinic, you get exposed to some really hard cases. A lot of times you're going to feel inadequate. You're going to feel like whatever I'm doing is not right. Why am I struggling with this case so much? First you see a tough case and you're excited to start it. But then after you start it, you realize then, okay, this is not easy. I don't know how I'm going to do this. After you've seen patients once or twice and couldn't complete it. After the third time, and trust me, I've had cases where I've seen patients 5 times for a single root canal. After third time it becomes really like, I really don't want to do this. But I've learned one thing, that sometimes a little magic happens between visits that help you gain a new perspective and that helps you solve the problem and complete your case. I would say mentally it's draining more than anything. One great thing about endo is that ergonomics, when you're working under a microscope, your ergonomics gets pretty good. So you're not going to have like back pain and neck pain and everything that you could have with all other, like with surgery or anything else that you're doing. It's not the case with endo. So yes, it's more mentally draining than anything else. You know, and whatever works for
I think next to the
again, I don't get it. Okay.
Okay, that's good. Yeah.
Anyways, I'm sorry about this.
No
I'm still
worries.
not.
No worries.
So, you know, what was helping me is to not study on Friday nights. Like, I have to have time for myself. I'm not going to do anything on Friday. And I also enjoy meditating. So I would meditate whenever I feel overwhelmed. So those are 2 tips that I give people. You know, you still have to have time for yourself, no matter what.
Okay, and when you first decided to come to the US, what was the mindset and where did you seek for help or start the process?
That's a great question. So I would never want to go back to that time because I think that was the hardest time in my life. As a internationally trained dentist, you first have to take MBD Part 1 and 2. So I remember when I was studying for mine, and I know this is not hard for American students, but imagine me, somebody who graduated in 2011. I started studying for my boards like MBD Part 1 and 2, like end of 2016, beginning of 2017. So I've been out of school for many years. My entire training in Serbia was in Serbian. So all of a sudden I'm exposed to new nomenclature, new language, new everything. That was really the hardest time for me because I felt like I was really alone. I know advanced standing programs were really competitive. I went to UIC open house one day and I met all these people who were like, some of them fail MBD Part 1, Part 2. Some of them are, have been applying for years. They can't get into dental school. So just meeting them, I was like, okay, my anxiety went through the roof. And I feel like if there's one tip I could give, it would be you have to believe in yourself. You have to believe that no matter what, you're gonna get there. It may not be easy, but there is, things do get better. Then there is definitely light at the end of the tunnel. But yes, studying for MBD Part 1 and 2 and applying for dental schools was the hardest time in my life.
And also, as you said, English was not your first language. So
Correct.
it must be really hard to start from the beginning. And to the follow-up question is, why do you choose US? Why do you choose after been training for years?
That's a good question. It's just like it happened that my personal life brought me here.
Okay. Let me see. How is dentistry different in Serbia and the US?
That's a great question. I feel like culture is different. I feel like people value their dental health a little bit less over there. And again, it also depends on which kind of environment you go to. In urban areas and like large cities, people do tend to have a higher degree of their oral health awareness. But in rural areas, it's just not the case. So that's one thing. The other thing is. I feel like dentistry over there is is very driven by what patient wants. I'll give you an example. Patients don't see a dentist for years, and then they come and they're going to say, I want you to fix my front teeth only. So you are limited by they don't allow you to do comprehensive care. This happens a lot. It's not like 100%, obviously, but it happens a lot. So you're not allowed to do comprehensive care. So you're going to limit yourself to doing what patient wants, versus maybe they need root canals in the back, maybe they need extractions, maybe they need many other things, but they're not interested in that. They only want the aesthetic area addressed. So what that comes down to is you need to make a lot more compromises, I feel. At the same time, I was very fortunate to have worked in a practice where the patient pool was kind of like upper middle class and more educated. So it was less of that. It was less of compromises, more really comprehensive care, and they would let us do whatever we think is best for them. But yes, definitely something like that. that. Also, another thing that I think is different between dentistry in Serbia and here is, and I feel like people here are more interested in knowing, okay, what are my options? What is the success rate of this? What is the success rate of that? So they're going to ask you these really smart, targeted questions. I feel like over there, that's still not the case. People still may not be aware that they have multiple options. They may not be necessarily aware that you can go to somebody else. Maybe he can do a a specialist treatment for you and do something more advanced. So they would rather, okay, what does the doctor think needs to be done? It needs to be done. That's it. So those are the main differences. Technology is probably more advanced here, but again, it really depends on the place. It really depends. That's pretty much main differences.
Okay. And will you expand on your personal statement? Could you give some tips on the structure?
That's a great question. So one thing that I would say, keep it short. Nobody wants to read a long personal statement. You want to keep it short and sweet. And you want to capture the attention within first 2 sentences. So when I started my personal statement for undergrad was something, it was kind of cheesy when I think of it, but it was also cool. I wrote something like my story starts with a dream, becoming a dentist and becoming a dentist where left-handed persons can't be accommodated or something like that. But I literally mentioned in my first sentence that I'm a left-handed in a country where only right-handed dentistry is practiced. And I feel like that was interesting. That captures their attention. Then they want to read all the way through the end, because I don't know how these admissions committee works, but I do know that they're very busy and they don't have time to read through everything. So you want to give them the gist in the personal statement. So yeah, I would just say, start with something, try to capture their attention and work around that. I would say I prefer 1-pager personal statements.
1 page.
I don't think anything needs to be long. I just think you need to kind of capture the gist and explain why are you passionate about the thing you're passionate, and if there's something interesting about you, you want to mention it there as well.
Okay. And how and what did you do to be the top one in your class?
Sorry, can you repeat the question?
How and what did you do to be the top one in your class?
That's a good question. So, well, there's, I worked hard. I studied hard, but there's also beyond that. You need to be smart. So for example, for your courses, you want to look at the syllabus and you want to know what percentage goes to different portions of your grade, right? Like this performance exam is 12%, but this one is only 3%. So you want to focus on the part that it carries more weight. You want to excel on that. For me, I had good hand skills. I had the experience, but still I was coming every Saturday to school to do lab work and to practice on for pre-clinics. So I sacrificed a lot of my time on that. I would make sure that my lab work was always neat. So if I'm, pouring a cast for, let's say it's just diagnostic cast, I'm still going to make sure that it's nicely, that the edges are nicely trimmed. I will go beyond my way to make everything nice and smooth so that it looks really pretty when you look at it. I was neat about that. So those are the things that probably made me stand out in the clinic, the way I was treating my patients as well. That is probably something that came easier to me than to others because I had some prior experience. But again, I was very thorough. You want to make sure you don't miss anything, That's number one. Number two is, studying for your exams. making sure you do well on exams, because somehow it comes down to these exams and I'm talking about didactic, not performance exams. For most of the courses, they carry a lot of weight. So if you do well on those, like even if you're not good on performance exams, that tends to kind of compensate. But again, I will say just, study your syllabus. The first thing you get when you start a course, you get the syllabus, study the syllabus, see, the percentage of the grade, and work hardest towards what carries most weight. I'm sorry, my dogs
No
are
worries,
going.
no worries. Okay, so what are some tests to determine if Pope is alive or dead?
Sorry, can you let me just kick the dog out of the room? This is he's
Okay.
getting annoying. Okay, I'm sorry about that. Can you repeat the question, please?
Yeah. What are some tests to determine if Pope is alive or dead?
If
the Pope is alive
Oh,
or
okay,
dead.
okay. So that's a great question, and it's the two most common pulp sensibility tests that we do are cold test and EPT. So cold test is the one that we do first, and we do it most of the time. A lot of times teeth are not going to respond to cold. What we do then, we do the EPT. So if it doesn't respond to both, there's a very good likelihood it's dead. Another test that we can do is cavity prep, which means you drill into the tooth, and once you hit the dentin, if patient still doesn't feel anything, yeah, it's most likely dead.
Okay.
That's something that we very rarely do, because most of the time you can do cold test and EPT, and you can cold test any tooth. EPT, though, you can't do on teeth that have crowns. Okay, yeah.
We have a last few questions. Can endo-treated teeth undergo orthodontic treatment?
Yes, they can.
And how to handle an avulsed tooth?
Oh, that's a great question. So how to handle it? So the guidelines have been changing over the years. Back in the past, they used to say if the tooth has been avulsed for longer than 60 minutes, I don't even bother replanting it. Well, now we say you should still replant the tooth. So what we do is the most critical thing when it comes to avulsed teeth is how long have they been out of the socket, and what medium have they been stored in. The best thing to do would obviously be if a parent or whoever is around, and it mostly happens on young kids, but when tooth is knocked out, you want to find it, you want to kind of rinse it out from whatever, if it has any visible dirt on it, and you want to put it back in the socket. That would be the best thing to do. Sometimes that's not possible, right? In those cases, you want to transport that tooth to the closest dentist as soon as possible, in some sort of solution that is that has a favorable effect. So you don't want to use water, but you want to use something like sterile saline or milk, or there's plenty of other mediums. Like there's a ton of studies. Some say you can use egg white, coconut milk. Can't remember what else. There's this thing called Hank's balance solution, which is save a tooth. It's known as save a tooth, but many people don't have that. But you will have milk or saline or egg white, around. So those are all good storage mediums for transporting the tooth. But really, you want to see, tooth needs to be replanted by a dentist as soon as possible. So when we see patients, we try to reposition tooth. We obviously always do take a CBCT on all the trauma cases to see if there's any other trauma going on. We will replant the tooth. We will use a splint, some sort of like semi-rigid splint for about 2 weeks, and we will also initiate the root canal treatment if that was a mature tooth. You want to initiate the root canal treatment as soon as possible because you want to avoid the possibility of inflammatory resorption, which is one of the most common complications of Wahl's teeth. But with immature teeth, with kids with open apices, there is actually some chance for spontaneous revascularization, believe it or not. So if you replant the tooth, that means the pulp inside it could still stay alive, which is pretty amazing. And I've seen some long-term follow-ups that teeth surviving and gaining length and closing apices. So that's pretty remarkable.
And the last two question is, how is your life now as a dentist? Even though you're still in the residency, but how is it like now? Is it better than back in Serbia?
It's 1,000 times better. I would never go back. I'm very happy where I am. I think getting into dental school here was the best thing that ever happened to me. And then getting to endo was even better than that. So I think the day I got into endo was the happiest day of my life. I am so happy that no, I would never go back. I don't think I was happy as a dentist in Serbia, and I'm very happy right now here. I'm very happy as a resident, and I'm pretty sure that I will be happy as an endodontist, because guess what? All endodontists I know are very happy.
Okay, and the last question is, what's external root resorption and what's it cost?
External root resorption is we still don't know what it's caused with. Like we know what are the risk factors, but we don't know what is the exact specific thing that triggers it. So when you have certain imbalance between the cells that they're called osteoclasts, the cells that eat the bone. If there's some disturbance to the cement, cement is the layer that covers the root surface. So whereas there's some disturbance there, they may actually start eating dentin of the root. And they make a small hole on the surface and then start going like deeper inside, like up and down, until they reach the pulp inside the tooth. Typically, external root resorption does not penetrate into the pulp, but does get very close to it. So nobody really knows what causes it, but there are some risk factors. Orthodontic treatment is known risk factor. Then some periodontal treatment as well, like if a patient had scaling, root planing, also osteosurgery in the area. Those are the two biggest risk factors. Another thing, and this hasn't been confirmed, but they're speculating that there is a feline herpes virus. So herpes virus that is passed on from cats. That is linked with this external root resorption. Several years ago, Monarchs, he's a Dutch oral surgeon. He published a case series about the people having external resorption of multiple teeth. And in 3 out of 4 cases, he actually found that there was some link to cats, patients having cats or being exposed to cats. And one of these cases even had a cat that had external root resorption. So both the patient and the cat. So that's one, interesting thing about that.
Thank you so much. I think that's all we have for today. And for the viewers, the quiz link will be in the bio, and remember to do it before it's expired. Thank you.
Thank you so much. It was my pleasure being your guest today, and I really appreciate it. You guys can find me on Instagram as Endodontist. I'm always happy to answer any questions you may have. Thank you for everything.
Thank you.